run today's session. We thank you very much for joining us. Today's session is the third in a series of our annual Mayday event, which is about workplace mental health and injury/harm prevention related to it. And we're very excited about today's session, which is about activating knowledge for workplace mental health, and particularly focusing on some research projects that are running in Ontario with our different partners. So it's a really good chance to understand ongoing research and even some early results in some cases, and then to have a discussion about research in this space and what more we could do collectively. So I think the live streaming has started.
Yes.
Yep, great. Sorry, just making sure. And so I'm really excited to welcome all our speakers here. We're going to start with a presentation from the Institute for Work and Health by Emma Irvin and Emil Tompa. I have short bios that I just wanted to welcome them so you understand who's presenting. Emma is the Director of Research Operations at the Institute for Work and Health, where she oversees research planning, research operations, information systems, and the internal library. She's also an adjunct appointment with the Department of Rehabilitation Sciences at the University of Toronto. Emma also oversees the Evidence Synthesis Program at IWH, one of the Institute's key research programs. Her research focuses on the methodology and conduct of literature reviews, from scoping to systematic. She teaches systematic review methods in a number of forms. Dr. Emil Tompa is a senior scientist at the Institute for Work and Health. He holds appointments as an associate professor in the Department of Economics at McMaster and an assistant professor at the Della Lana School of Public Health at U of T. Tompa is a labor and health economist with an MBA from the University of British Columbia, an MA in economics from U of T, and a PhD in economics from MAC. Tompa is the Executive Director of Inclusive Design for Employment Access, or IDEA for short. IDEA is a social innovation laboratory with a mission to help create stronger and more diverse labor markets that include persons with disabilities through evidence-informed policy and practice. IDEA identifies, develops, evaluates, and disseminates tools and resources that address critical needs of organizations in their efforts to be inclusive workplaces. Tompa's research interests include the consequences of occupational health and safety system design on the health and well-being of individuals and populations, the economic evaluation of workplace interventions for improving the health and well-being of workers, the economic burden of adverse health conditions and disability, and the analysis of disability policy systems. So I'm going to turn it over to Emma and Emil to talk about their current post-traumatic stress disorder study, although it's PTSI, so that'll be the first thing to clarify, is we don't call it D anymore. And I'll turn it over to Emma and Emil to share their research and the learning thereof. Thanks.
Thanks, Val. So I'm going to go first. Emil is driving, that we're co-presenting this presentation. As you mentioned, it's on evidence-informed workplace policies and practices for PTSI disability and prevention. And this project was funded through the Alberta Supporting Psychological Health and First Responders series of grants. There we go. So just a quick presentation overview. We're just going to talk about the project team, give you a background, what our research goals and methods were, very high-level methods, don't worry, and our preliminary findings. And then some time for questions. So this is our research team. The co-PIs are Dr. Dwayne Van Aert and Dr. Emil Tompa. We also have colleagues from the University of Alberta, University of Regina, and the Wayfound Mental Health Group, and a number of amazing stakeholders. Next slide, please. So occupational injuries, as you can imagine, are quite common for first responders. A particular challenge, though, for this group of workers is post-traumatic stress injuries or occupational stress injuries. So PTSI is quite a considerable burden for the first responders, but also their families and their work places and society. And recent studies have shown that occupational policy practices have an important role and impact on PTSI prevention. While the scientific evidence for PTSI interventions is modest at best, you'll see soon what I mean. While there are other forms of evidence, right? So there's evidence within the organization themselves and what they're doing to protect the workers, and that's what we sought to find. So the model we use to guide the project is based on David Sackett's evidence-based medicine, where, as I mentioned before, we're taking evidence not just from the research literature, but also looking more broadly at other experts in the area and locally within Alberta for people who are on the ground who are actually working in that area. And we're going to describe that a little bit more in the next few slides. So the objectives, the purpose of the study was to develop a resource targeted at improving the prevention of PTSI work disability in Alberta's first responder organizations. As I said, we have the 3 stages. One is an environmental scan of international first responder organizations, policies and practices, which Emil is going to speak to. The second was a summary of the scientific evidence looking at reviews of reviews. And the third were semi-structured interviews of OHS practitioners, managers, supervisors, and workers within Alberta first responders to get more detailed information about what their current practices were. Over to Emil.
Okay, so I'm going to talk about the phase 1 environmental scan. It was a scan of international first responder organizations, programs, services, and practices for the prevention of PTSI work disability. So we spoke to organizations across Canada as well as internationally. We have a listing here in this table. You can see a number of firefighter organizations, paramedic organizations, and police organizations, as well as a category we call other, which includes participants who work with more than one group of first responders, for a total of 35 interviews that we did with various organizations around the world. In terms of the interviews, we did a thematic analysis of what we heard people speak to about their experiences of providing different types of programs in the field. And we identified 10 themes, which gave us some understanding of sort of different facets of these programs and how they work, whether they worked well, what they found to be some of the issues around providing PTSI services for first responders. So the first theme was about specialized programs and services. There was a sentiment that you really needed to recognize the unique experiences of first responders that were obviously very different than other sectors where maybe there might be need for PTSI services as well. But they felt that it was important to have a very specialized service that understood the context of those work experiences. Multiple programs were developed to provide this kind of customized support, and I'll speak to some of the programs we heard people speak about in a subsequent slide. What they found was generic programs such as EAP or EFAP that are often provided by organizations were not very effective. That's why they felt there was need for specialization. A second theme that was mentioned a lot was the stigma associated with mental health in this sector. The notion that people working in this sector need to be tough, heroes, really macho culture. This is an image that they often mentioned that was sometimes a barrier for even support seeking by people who suffer from mental health issues as a result of workplace exposures. So the challenges associated with expressing feelings and acknowledging the need for support was one of the things they confronted a lot and tried to navigate and make it more comfortable for people to come forward to seek support and to speak about their needs. Another big issue was also about confidentiality and anonymity. There was a sense of sometimes there was a lack of trust with in-house services. If the person was a staff person who was supporting some of the mental health needs, they weren't sure whether exposing their vulnerabilities to these people might affect their careers. That was often mentioned, the concern about the impact on their career progression if they were identified as being somebody who has mental health needs. Related to that was a stigma, and this was addressed through multiple pathways for support seeking as an alternative to having in-house services. So allowing people to seek support outside and providing those services through an external provider was a really important option that first responders felt they needed in order to maintain that confidentiality. Training was mentioned a lot, training at all levels, on an ongoing basis as well, not just one-time training, but a refresher training on a regular basis. At the front end, on onboarding, doing screening and training for mental health resilience was absolutely critical. Refresher courses and workshops on mental health and also things like nutrition and exercise, really thinking about the whole person and their health needs rather than just the mental health needs. And then also training for spouses and family members to better support and understand, the mental health of their loved ones who are working in this sector, because that the family unit was often affected by mental health issues of first responders. Another theme was about communication, really ensuring there's awareness of the supports that are available so that people know where to go when they need the help. Providing information sessions on mental health, nutrition, and exercise. So really just getting people to understand that they need to attend to these kinds of issues on a regular basis. Sometimes having posters to encourage being mindful of your own mental health, also providing peer support, and also about the availability of supports. A common theme we also found was the discussion of thinking about the whole person rather than compartmentalizing people's needs, thinking, okay, they need mental health needs for these kinds of issues, they need needs of other sorts for other physical health issues. Think about the whole person. That's where things like nutrition and exercise and work-life balance and wellness really fit in together with the needs for mental health issues as well, kind of thing. So really think about the whole person, how all those facets of your life connect and can help build up that resilience. Family health well-being was also an important part of the equation. And then community building and social cohesion through group events as well, having that camaraderie, that support network on a regular basis, knowing that your peers, your colleagues are in there supporting you through all the kind of ups and downs of work experiences was really important. I mentioned also about the need for multiple avenues for support seeking, really allowing for different needs and preferences and abilities to maintain privacy and confidentiality. So provision of internally funded and provided programs and supports was often the case, but also having external options as well. So availability of externally provided programs through, sometimes it was through a labor union or workers' compensation was another option that sometimes people turn to as well as the public health system. Another theme was about the continuity of services, so across the employment journey, including at onboarding, as I mentioned, maintenance, refresher courses during absences and return to work, and also through career advancement as well, thinking about the person's journey in their employment experience with that organization. Important to think about including supports even after exit due to possibility of late onset. So people who may be retiring from the service as they get older and retire out of work, they may still need some of those supports. So thinking about what kinds of support you may need to provide for people as they ease into retirement. So also thinking about the continuity of supports from primary prevention, that resilience training may be considered sort of a primary prevention approach, secondary prevention when there's early symptoms, and then tertiary when there's more serious symptoms. So really making sure that person has the services needed to get back up to full form and get sometimes maybe return to work as well if they're taking some time off work. I mentioned the whole person approach, which also includes family and community. People also mentioned a lot the value of research, doing both in-house assessments through surveys, audits, monitoring, and evaluation to make sure the program was meeting people's needs and was serving the full panoply of kind of needs that people have. Many key informants also spoke about ties to academics and the importance of having rigorous research evidence to support some of the investments they did in these different programs. Emphasis was really given to evidence-informed programs, services, and practices. So they really valued those linkages with external bodies and research organizations that can help support that evidence base. And they noted the need for continual improvement approach through ongoing assessment, scanning, and research. This environment is changing all the time. New knowledge comes up to speed where it gives us some insights how you can do a better job of providing for the needs of first responders when they suffer from PTSI. So keeping abreast of all of the research developments and thinking about how you can do a better job within your organization is a really critical part of the way they ran these programs. Another thing that came up a lot also is about resource constraints. It was noted particularly in certain contexts where there were small operations, maybe rural operations that didn't have a whole lot of resources to offer a full range of services. So that was often an issue. Sometimes it was about people time constraints due to extensive demands of their job, particularly during COVID, and there came up a lot of discussions around some of the constraints during COVID. Funding cuts were also mentioned, and budget constraints that made it difficult to provide the full suite of services. And as I mentioned, noteworthy were smaller regional services, particularly first responders who are volunteers who do this kind of on a part-time basis. They may have other occupations that take up most of the time. Those kinds of organizations didn't often have a whole lot of resources available to them to provide a full range of services. And sometimes there wasn't the service available in their region as well. So finding the expertise that you needed was sometimes a challenge because it wasn't available in the community. So that's the 10 themes that we identified. In the next few slides, I'm going to talk about some of the types of interventions we heard people speak about. And we've clustered them into 4 broad categories. The first category is about individual directed interventions to develop the skills to both mitigate the development of PTSI and other mental health conditions. Then there's the peer-directed interventions that develop skills for increasing that social support that you want your peers to be able to provide you when you have needs as an individual with PTSI and other mental health conditions. And then there's the supervisor-directed interventions that develop the skills for creating a supportive work environment. Also important for supervisors to be aware of some of their workforce that may be showing signs of symptoms or early identification, and enhancing their communication skills to help them be able to better provide those supports when they see people having early symptoms. And then there's population-directed interventions aimed at developing a combination of both the individual, peer, and supervisor skills, but they're really targeted across a population of a particular constituency within a particular first responder organization. So I'm going to speak a little bit more about some of those programs we've heard about at those different levels. So the cluster 1 was the individual directed interventions. The first group is about emotional self-regulation, so building up that resilience. So training interventions aim to change the emotional response of individuals. They were often a mix of psychoeducation, directed exercise, mental focus and awareness, cognitive behavioral therapy, meditation, self-practice, and sometimes mobile games as well. And some of the specific programs we heard that fell under this category are Road to Mental Readiness, or sometimes abbreviated as R2MR, Coherence Advantage Program, or CAP, Biofeedback Assisted Resilience Training, or BART, Mindfulness-Based Resilience Training, MBRT, Mental Health First Aid, so O2X. It's about eat, sweat, and thrive, and resilience at work, and then systematic self-reflective training, or SRT. So that's the emotional self-regulation group of programs. Some of these programs fit into other categories as well, so you'll hear some of the same programs being listed in other clusters as well. So cognitive self-regulation, retraining interventions aim to change the cognitive response of individuals. So it's a mix of stress response, psychoeducation, exercising strengths, adaptive coping strategies, self-efficacy, social support, and also self-reflection. The examples are some of the similar programs we heard about in the earlier cluster, the MBRT, MAPS, mental agility, psychological strength training, or MAPS, Master's Resilience Training, or MRT, Resilience at Work, the RAW program, and the Systematic Self-Reflective Training, or SRT. Cluster 2 is about peer-directed intervention. So this is about your colleagues being able to provide peer support. So peer traumatic risk management training for early identification of high-risk individuals, and group sessions to understand cognitive and emotional response to exposures. And sometimes it was about educational sessions that increase peers' awareness of symptomology and treatment for mental health conditions, and enhance the ability to provide support to your colleagues, and practice in facilitating supportive conversations with your colleagues as well. So examples of where some of this kind of training was provided was through mindfulness-based resilience training, or MBRT, the RAW program, also the critical incident stress management program, or CISM for short, the traumatic risk management, or TRIM program, and then a Schwartz round, and then group counseling as well. We're all under this cluster. The third cluster is focused on supervisory skill sets. So supervisors directed training interventions through education. It included a mix of psychoeducation, workplace mental health risk, supervisors' roles and responsibilities, and their communication skills. Similar to the peer training interventions, it was meant to increase the ability to recognize symptoms of mental health conditions amongst your colleagues, ability to support subordinates experiencing psychological challenges, so providing that supportive kind of role, facilitating supportive conversations so you can communicate better with your colleagues, the people you work with, increase awareness about mental health risks specific to workplace and occupation, and awareness of responsibility for creating a supportive work environment. So all of the kind of package of things you want your supervisor to be good at in terms of helping support the workforce that they oversee. An example of that program was the Respect program, and another one was called Head Coach. And then the fourth cluster is about population-directed interventions. This is covering individual, peers, and supervisory kind of training programs, all in kind of sort of a package of training. So these are population-directed, multi-component, combining individual-directed education, peer and supervisor-directed early interventions, crisis management and resource access, and also organizational-directed new administrative units. And the key example of that kind of a program was called Together for Life. So just summarizing some of the things we heard across the 35 key informant interviews in terms of promising practices. And in the second slide in this bit, I'll be talking about some of the challenges we heard about as well. So in terms of the promising practices, it was commonly emphasized the need for looking at the total worker health kind of issues, right? Including the family as part of that, the worker health across the entire employment journey. So really the whole person approach, as I mentioned earlier on. Leadership training was really critical to improving how to care for employees, particularly in a supervisory management role. Providing top-down support, championing worker health and well-being. So from senior management, critical for them right through all the management levels to be supportive of workers' needs, particularly mental health needs. Relationship building across the organization so people can provide the support to their peers. Diversity and inclusion initiatives to ensure that everyone feels welcome. So really that's a pretty important thing to get past that macho culture where you allow people to be themselves, and the diversity that you see in the labor market you want to see also in your workforce. Conducting research, as I mentioned, was really important to determine best practices and support that continual improvement process. So I have 6 points here from the Royal Foundation, 6 voluntary standards that someone spoke about in one of the key informant interviews that we felt really resonated on how to go about addressing these issues in a pretty structured way. So prioritizing mental health in the workplace and developing and delivering a systematic program of activity. Ensuring work design and organizational culture drive positive mental health. Promoting open culture around mental health, being comfortable speaking about your health needs. Increasing organizational competence and capabilities for training. Providing mental health tools and supports as needed, and increasing transparency and accountability through internal and external reporting. And then some barriers and challenges that we heard people speak about. I mentioned about the culture where support seeking for mental health issues is considered a sign of weakness because of that macho culture that came up a lot in the conversations we had with the 35 different organizations we spoke to. A lack of trust and confidence in the management, particularly with the use of in-house services. As I mentioned, that was a big issue as well. Concerns about the potential short and long-term impacts of one career as well. That was really critical. People felt that if others knew about their mental health challenges, that they might get sidelined in terms of career opportunities. Service providers not having the knowledge of first responder experiences was another issue they talked about, and needing that very specialized, customized service where the service provider really understands the sector and the kinds of experiences people experience as first responders was really critical. So the generic services, as I mentioned, weren't very helpful. So the program is not customized to the context of first responder experience. So it's one of the big challenges we heard about. Lack of funding, as I mentioned, lack of service availability in rural areas, lack of leadership and buy-in and leading by example, another important thing, not having top management really supporting these kinds of things. Long shift hours and long commutes that really restricted time for first responders to seek support. Lack of quantified measures of overall effectiveness of the programs was another thing they mentioned too. They really valued having that research knowledge to understand what works well and what doesn't in different contexts. And that gap between research and its translation into evidence-informed decisions was really something that they were challenged with and felt they needed more knowledge about research and knowledge to practice approaches. I'll pass it on to Emma for stage 2 and stage 3 overviews.
So stage 2, so just a reminder that that was the summary of the scientific evidence where we did a review of reviews. So we did a review of systematic reviews that looked at the effectiveness of workplace-based interventions to reduce work disability. There were 3 reviews that met the inclusion criteria. They were published in between 2020 and 2022. All 3 were conducted in Canada. They had slightly different focuses. And so one was on different psychological interventions, one was on peer and crisis support, and one was on more psychotherapeutic interventions. The populations within the 3 reviews were police, firefighters, paramedics, and one that looked at all 3. And the outcomes across the 3 reviews were absenteeism, for example, resilience, stress, psychological distress, etc. So what we did across the 3 reviews is we dug down into what were the individual studies and what were the effects of those individual studies. So next slide, please. First, I'll just show you the results. The text that is in red is where we updated the review. So we ran the review at the beginning of the project, but because we knew there was emerging evidence in this field, we ran the review and we expanded the databases that we looked at. And this was information that we found through the reviews we looked at and also speaking to our stakeholder community. Next slide, please. So the interventions that had a positive effect, you can see here were interventions that looked at Respect, which is a program, versus waitlist control, etc. So I'm not going to read all of them, but you have the slides and we're happy to, please reach out to us and we're happy to give you more details because we have a summary table that captures each of these interventions by the outcomes that I mentioned on the previous slide and the population that the interventions were targeted within the first responder community. So these were with those with a positive effect. The next slide shows those with a negative effect and those that at this point do not have an effect. So next slide, please. So now I'm going into stage 3. So again, stage 1 was looking at international scan of different organizations. This is focused on semi-structured interviews with OHS practitioners, managers, supervisors, and workers within Alberta's first responder organizations to get more detailed information that was happening on the ground. So you can see a description of whom we spoke to. Next slide, please. And there were 3 main themes that sort of overarching themes that emerged from the interview data. And you'll see a lot of overlap, not surprisingly, with some of the themes that Emile has described. And then there were some additional themes that emerged from one of the questions we had, which was around recommendations. So first, I'm going to describe briefly the overarching themes. So the first is on improving culture. Next slide, please. And we have some quotes just to illustrate these themes. So the first is, in general, the feeling within the improving culture was that the culture was improving in each of the organizations, both within the organizations, but also societally. And that's what this quote speaks to. The other theme was that a lot of the programs and policies were under development. So they certainly saw that they were on the horizon, or they were actually in place within the organizations, and they were being the implementation stage was being worked through. And the last theme was something that, I think obviously we can see is extremely important, and it's around how important trustworthy communication is around the value of the programs that were being delivered. And that, as you can see just from the first line of this quote, that word of mouth was the biggest seller of resources that were available, where people had spoken to how they had benefited from them. So those are the core themes, and the additional themes were just, again, the importance of reducing stigma. Emil, if you could just, thank you, and how important that is to, as it says, how important it is to shift conversations around this topic. Another was around streamlining processes, that there are lots of entry points to the process. And obviously, if somebody's in crisis, they need to have a more streamlined process to be able to go through to. And just better resources. And to this point, just to also making sure that those individuals who are engaging with this community were more trauma informed and had the cultural competency to speak to this unique population. And I'm going to put it in the chat, but we are currently running an ECHO, which is a telementoring project that's being funded by the Workplace Safety and Insurance Board in Ontario, to build the cultural competency within those individuals who treat first responders for PTSI. So I'll put the link in the chat so you can go and investigate that. And that's it. Questions?
That's great. Thank you very much. It's a very comprehensive project that you're doing, and thanks for showing us so much detail. I don't see any questions yet in the chat, but I encourage people to put a question in the chat or raise their hand. But we also are we're right on time. I did want to ask, it always comes to my mind, and maybe it's my pipe dream of, like, did anything surface that we would consider primary prevention in this? I mean, the trauma is external in most cases, I guess. So obviously we want to prevent all those external bad things from happening. But even in the, so I guess we are in general guarded about the fix the worker kind of strategy to prevention. And yet, of course, resilience and that kind of thing are important, and having the opportunity to talk about things. So what I would consider that secondary prevention, right? So, but did anything, has anything surfaced around, the organization of teams, the support of teams, the staffing complement that's needed to respond to something, and how the trust relationships are so important beforehand, I guess, to build some of that, and any of that could be, that isn't just about expecting a potential for harm and building all the, the protections. Is there anything actually organizationally that can be done to prevent the harm?
Mhm.
Did anything like that?
Yeah, that's a good question. I can just speak to from what we heard from the organizations that we spoke to around the world. I tend to put it all into that kind of whole person approach, where you're thinking about the person's health and well-being all the time. If somebody has a good work-life balance, good nutrition, good family life, supportive colleagues, and knows how to address exposures so that it doesn't affect them, debriefing sometimes when there's traumatic things happen, things like that, as a team. There's various kind of good practice you do on a day-to-day basis that just helps build, the overall ability to cope so that it doesn't affect you in the same way, kind of thing, that you have that resilience. So it does end up being about resilience, but it's a more fulsome look at things. It's not about just resilience training specifically for mentality, but resilience training in terms of life ability to kind of be strong and resilient as a person through. And then they talked a lot about meditation, yoga, nutrition, all the things that just build for a healthier lifestyle, kind of as being really critical inputs into being resilient.
Mm-hmm.
And the only thing that comes to my mind immediately, Val, in addition to what Emil has mentioned that did come up also, just the culture of supporting families as well, was just normalizing the behavior of talking about feelings and emotions, whatever they are. So there was an example of a supervisor who would come in and talk about, I didn't sleep well last night. I, was revisiting what happened yesterday, which was not a traumatic event, but again, just normalizing that it's because as Emil talked about, the culture in the past had not potentially valued those kinds of conversations. So somebody did speak to how much they appreciated that, so that when it came to a situation where they did need to talk, they felt that it would be accepted.
Great, interesting. And I didn't, and maybe I may have missed, was there anything even about, I always think of it, once again, you can see how I default to organizational, but like anything around mandatory sleep cycles, or, you know, for extended exposures, anything or any research around that, about the amount of sleep and rest time away from the ongoing trauma, and how beneficial that can be, or not, I guess. Did that turn up at all?
It's not in a big way, but they did mention about work-life balance, you know, like, you know, having the ability to turn off and go home and be with your family and, you know, have quality time outside of work. What was mentioned a lot, so that the balance was really, really important, I think. And that, I guess, feeds into the kind of things you're mentioning.
And the ECHO program that you're doing, I think you mentioned, Emma, that people can register and see that later. You've already got a cohort that's participating, but that
People can still join.
Oh, okay.
Yeah,
And
people are welcome to join.
and it's about, my daughter's an emergency physician, actually, and I certainly have, even, you know, I've been in her home when she's come home from shifts that were extremely upsetting for her and for her team. So this is targeted to potentially to them treating incoming first responders, but I guess, is there an element for the medical community itself who have secondary exposure, I guess you might say?
It does not address that specifically. It is really just about building the cultural competency in treating practitioners who are treating first responders for PTSI. However, there is the value of the community, right? That's very much why it's such a community-based program, to see that there are other individuals who are experiencing what you may or may not be experiencing, and there's a great deal of support. It's very, very powerful.
Okay, thanks. There's one more question and then we'll move on. And Ken, we're not having audio quality, like where I'm sitting, the sound is okay. And I think others have indicated that, but anyways, thank you for letting us know that you're having some difficulty. And Paula had a question about correctional officers. Have they ever been included in the groups of participants to study? And okay, that's getting into our next subject, actually, around suicide, but just the question is, are they included in any of the cohorts that you've looked at in this study, or in the scan that you did?
Not in the work that we did here, but in other work. Not I think I've seen some of that kind of research being done with also people in the armed forces and as well, kind of thing. So when I did another study where we looked at a broader panoply of literature, that we included correctional officers as well as veterans in to look at the kinds of programs they have for PTSI in the broader constituency, as well as first responders, but not in this particular study.
Okay, thank you, and thank you both for your talk and for staying till the end. So if we have time, we'll have a bit of more discussion about this kind of research and what more can be done, and potential participation in the ongoing research. So now we're going to switch to Dr. Stephen Biddle, who's going to present on understanding work-related suicide and his current study. And I would like to welcome him